Dr. Aquatli, like Dr. Bergella mentioned, is at a conference, but she was very helpful in picking the topic and going over my slides. So genetic mosaicism is the presence of two or more cell lines with different genotypes arising from a single zygote and a single sample. It can be generalized, so that means if it's present in the entire organism, or it can be confined to a specific compartment, so like the placenta, the fetus, or a different organ system. Depending on if improper chromosome segregation occurred during meiosis or the early postzygotic mitosis or the late post-zygotic mitosis will determine whether it's generalized or confined to a specific compartment. Generally speaking, the earlier in development that an abnormal chromosome segregation event such as non-disjunction or trisomy rescue occurs, the more widespread the mosaicism may be in the differentiated organism. Later chromosome segregation events are more likely to be confined to specific cell types, which gives rise to clinical findings such as confined placental mosaicism, which leads to discordant karyotypes found with CVS versus amniocentesis. By understanding the developmental origin of the cells biopsied via CVS, amniocentesis, or postnatal karyotyping, clinicians can use the appropriate testing methods to distinguish between placental mosaicism and generalized mosaicism. So the next couple of slides are just a brief overview, just going over the basics of genetics again. First, we have mitosis. So mitosis is the process when a single cell divides into two identical daughter cells. So it's kind of what happens in most cells in our body. And then we have meiosis, which is the process where primordial germ cells are diploid and give rise to gametes, which are haploid, so 23 chromosomes. So your total DNA goes from like 4N to 2N during meiosis 1 and from 2N to 1N during meiosis 2. And then in males, this is generally a short process. It's approximately 64 days. It has its onset at puberty and is continuous throughout a man's reproductive life. In females, oogenesis begins in utero, but stops during prophase 1 and is dormant by 8 months gestation. Meiosis 1 resumes at puberty, and then each month another one or more oocytes resumes reproductive reduction division. Meiosis 1 is completed at the time of ovulation, wherein the first polar body is formed, and meiosis 2 begins, but once again is halted at this time during metaphase, and then meiosis 2 is completed only if fertilization occurs and you get your second polar body, and fertilization most often takes place in the fallopian tube. So just a quick review of fertilization. It occurs between the sperm and the ovum, leading to the zygote and then to your morula, which is 16 cells. Compaction creates a polarized zygote, and outer cells become the trophectoderm and their inner cells become the inner cell mass. And this distinction will be important as we keep moving forward. So in terms of mosaicism, there is somatic mosaicism and germline mosaicism. Somatic mosaicism is, it occurs during the embryonic or pre-embryonic stages and becomes an integral part of the organism. It's more than one cell line in, or more than one cell lineage in somatic cells, and it does not pass to offspring as the germ cells are not affected. So this can be kind of categorized into 3 groups. The first is aneuploid mosaics that involve a mixture of distinct aneuploid genotypes in an organism whose entire cellular composition is abnormal. So chromosomal aneuploid mosaics, a whole chromosome is missing, or there's one extra chromosome in a cell. There's euploid aneuploid mosaics, which is the bottom down here. It creates a mixture of euploid and aneuploid cell populations in an individual. Some cells of the body are aneuploid, so either 45 or 47, while some are euploid. So you can see the red ones over here that are 46. And the severity of the clinical condition depends on the proportion of the euploid cells. This mosaicism is more common as the embryo has more chances to survive during intrauterine life. Finally, there's paladoid mosaics, which is commonly called mixoploid embryos, which implicate a combination of different multiples of the normal haploid chromosome number. An entire set of chromosomes is found, has found access in a cell. So either triploid, so 69, or tetraploid, 92, and the embryo with the predominant triploid or tetraploid generally do not survive. But this can sometimes be found in liver and bone marrow cells. The important thing to remember as we move forward is timing is everything. So a mutation that occurs during the initial mitosis after fertilization, so your initial cell division, will affect half of all of your cells. And mutations before primordial germ cell differentiation may be present in both somatic and germ tissue. There is general mosaicism, so there's 2 or more cell lines present in the entire organism, and this may be the result of an affected parental germ cells, or there can be confined mosaicism where only a particular body part or organ is affected, and it may develop during organogenesis or during growth of the organ. Phenotypical expression depends on the number of cells affected, and this may happen either during intrauterine life, after birth, or later in life, depending on other factors. So this can range from, so the mechanism by which this occurs ranges from chromosomal abnormalities to single nucleotide alterations. There are 2 primary mechanisms. One is postzygotic mitotic non-disjunction, and the other is postzygotic mitotic trisomy rescue. So this is an example of the mitotic non-disjunction, and this is when whole chromosome aneuploidy can arise from abnormal segregation of chromosomes during anaphase lag due to either mitosis or meiosis. And then the other mechanism that we talked about is trisomy rescue, and this is a genetic phenomenon in which a fertilized ovum containing 3 copies of a chromosome loses one of these chromosomes in anaphase lag to form a normal diploid chromosome complement. And if both of the retained chromosomes come from the same parent, then we see uniparental disomy. And the mechanism of trisomic rescue has been well confirmed in vivo, and alternative mechanisms that occur in trisomies are rare in comparison. So this was a nice table that kind of highlighted some of the more common types of uniparental disomy. Clinical consequences depend on the chromosome involved and include loss of heterozygosity and genomic imprinting. The loss of heterozygosity may result in expression of a recessively inherited variant where only one parent is a carrier. Genomic imprinting is an epigenetic phenomenon in which certain genes are modified during gametogenesis or prior to fertilization, such that they function differently based on maternal or paternal inheritance. So uniparental inheritance of imprinted genes cause significant clinical syndromes, and I think some of the ones that we've probably heard about before are Prader-Willi, which is caused by maternal uniparental disomy of chromosome 15, and then Angelman, which is the opposite, it's caused by paternal uniparental disomy of chromosome 15. The big ones that Dr. Akwatli wanted me to mention is Russell Silver, Beckwith-Wiedemann, which we know about, and then Angelman and Prader-Willi. In terms of germline mosaicism, these are changes in the nucleotide sequence of DNA and structural variation that occurs anytime after the formation of the zygote. Gonadal tissues that participate in gametogenesis is mosaic, and then individuals will not be affected, but will pass this on to their offspring. So structural variation is like a very non-specific term that includes large changes in the small and large changes in the genome. And then complex structural variation is when there are 2 or more breaks in the genome, and this can be large and actually seen on karyotype. And then germline mosaicism is also called gonadal mosaicism. And this was a nice visual to go over germline mosaicism. So it's presumed when a dominant trait is observed in more than one child of a parent who have no features of the condition. And the recurrence risk to offspring depends on when in the zygote development, the nucleotide change or the variation developed. So when the genetic change occurs early in development, it would affect all future gametes, and the risk of to offspring is 50%. So that's this top part over here. However, when the change occurs in one of the cell lines destined for gametogenesis well beyond the early zygote, the recurrence risk can be 4.5 to 8.3%. And it's higher when the parent of origin is female. In turn, the affected offspring can expect to transmit this to 50% of their offspring. And this wide range of recurrence risk in the index generation makes prenatal genetic counseling very difficult when germline mosaicism is suspected. Placental mosaicism arises from mitotic non-disjunction in cell lines destined to form trophoblast, placental mesenchyme, or both. This is found in approximately 1 to 2% of CVS cases. The karyotype or microarray comparative genomic hybridization, which is also called chromosomal microarray report, will describe 2 or more distinct cell lines. So to confirm the diagnosis of confined placental mosaicism, the abnormal cell line noted in the placenta must not be seen in the embryo, fetus, or neonate. Normal evaluation of amniocytes through an amniocentesis, white blood cells, either through like a PUBS procedure or postnatal blood assessment, or other tissue, which can be done through a buccal smear or skin biopsy, confirms that the abnormal cell line is found only within the placenta. So confirmation of confined placental mosaicism allows the prediction of normal development in surviving children. So it's important to distinguish if there is confined placental mosaicism. It's important to note that confined placental mosaicism has been associated with impaired placental function and is associated with growth restriction, which we'll talk about in a couple more slides. There are different types of mosaicism. So the presence of aneuploid cells confined to the external layer of the placenta is described as type 1, which is seen in direct culture, and this causes false positive cell-free DNA results. Type 2 indicates that the abnormal cell line is restricted to the mesenchyme only, and in type 3, both placental layers contain abnormal cells, which can generate false aneuploidy calls. More rarely, trisomy mosaicism or full trisomy restricted to the fetus with a euploid placenta can lead to a false negative result. Excuse me. And like I mentioned earlier, when you do have confined placental mosaicism, there is an increased risk of growth restriction. It's believed that this can alter placental function and lead to fetal growth restriction or perinatal death. The exact mechanism by which the abnormal cells in the placenta affect growth or placental function is poorly understood. This is most commonly seen with issues with mosaicism in chromosome 16. You can have severe growth restriction, prematurity, perinatal death, and less than 30% of these pregnancies result in normal full-term infants. It's also important to note that this poor outcomes are seen with other chromosomes. 16 is the most common, but you can also see it with 2, 7, 8, 9, 10, 13 to 18, 21, and 22. So next, I just wanted to talk a little bit about genetic testing and like implications for what we do in the ultrasound unit. I thought this was a very nice figure that kind of highlights what we're sampling with CBS versus what we're sampling with amniocentesis. So discrepancies in the karyotype between the placenta and the fetus can occur because the cells contributing to the chorionic villi differentiate separately and distinctly from those forming the embryo in early development. Lineage differentiation that occurs in the blastocyst stage gives rise to trophoblast cell lines and the inner cell mass. And the trophoblasts become the cytotrophoblast and the syncytiotrophoblasts of the developing placenta. Cell subsets within the inner cell mass over here will develop into the extraembryonic mesoderm, which make up the core of the chorionic villi, the extraembryonic ectoderm, and the fetus proper. Mosaicism. Katie, I think you're unmuted. Okay. Mosaicism can occur through meiotic non-disjunction with subsequent trisomy rescue or as a result of postzygotic mitotic non-disjunction. And to understand the implications of abnormal karyotype analysis seen on CVS or amniocentesis, it's really important to understand the developmental origins of these cell populations and what we're sampling with each technique. So this just kind of goes over the basics of amniocentesis. Cells in the amniotic fluid are derived from extraembryonic ectoderm, and that includes cells from the fetal skin, respiratory tract, urinary tract, GI tract, and amnion. Amniotic fluid after 16 weeks gestation may be analyzed directly by extraction of DNA from the amniocytes for hybridization-based methods of DNA analysis, such as microarray or PCR. Alternatively, or in parallel, the cells can be cultured for cytology-based methods, such as karyotyping. Cytology-based methods require the cells to proliferate in tissue culture for about 3 to 7 days of growth, and sufficient mitoses, when they're present, are stained, and the karyotype is analyzed. The cells are grown in flasks and harvested and analyzed together. And those grown on cover slips are analyzed in situ as individual colonies. Amniocyte culture is actually quite reliable, with failure occurring in less than 1% of cases. Of note, the microarray and PCR can also be performed on DNA from cultured amniocytes and is customarily done to confirm any results from the original direct analysis. Excuse me. So when you have a mosaic result, it occurs in 0.1 to 0.3% of amniocentesis cases. The most common etiology is pseudomosaicism, which is when the abnormality is only evident in one of several flasks or confined to a single colony on a cover slip, like we talked about before. In this case, the abnormal cells have arisen in vitro and are not present in the fetus, and therefore they're not clinically important. True fetal mosaicism is seen in 0.25% of amniocentesis. And like we talked about earlier, this can be due to either postzygotic non-disjunction or meiotic errors with trisomy rescue. And a third of those will result in diploid cell lines that will be affected with uniparental disomy. So in terms of next steps, you can karyotype fetal lymphocytes from like a pub sample, excuse me. But it's not valid if the mosaic cell line involves other fetal tissues that are not found in the fetal hematopoietic compartment. An example of this is chromosome 22. Mosaicism is excluded from the fetal blood, and that may require additional fetal tissue such as skin or postnatal biopsy. The next steps also include detailed ultrasound assessment and follow-up for fetal growth. If both the ultrasound and fetal percutaneous umbilical blood samples are normal, then the parents can generally be reassured that in most cases the fetus is unaffected. However, there is a small chance of fetal involvement because the presence of an undetectable but clinically significant abnormal cell line can never be absolutely excluded. And that's why we continue to follow with to look for signs of growth restriction. So in terms of your CVS, so your chorionic villi have 3 major components. You have your outer layer of hormonally active and invasive syncytiotrophoblasts, a middle layer of cytotrophablasts from which syncytiotrophoblasts cells are derived, and an inner mesodermal core containing the blood capillaries and the mesenchymal stroma. The cytotrophoblasts and syncytiotrophoblasts derive from the trophoblast layer, which differentiates in the blastocyst stage, and the villus core derives from the extraembryonic mesoderm of the inner cell mass, if you remember that earlier picture, and it'll be coming up in the next couple slides as well. So we all know how to, or have seen a CVS procedure. The average sample will produce 15 to 30 milligrams of villus material. The villi are collected in a syringe and are transferred for inspection and dissection under a microscope to eliminate adherent decidua. They're then exposed to trypsin to digest and separate the cytotrophoblast from the underlying mesodermal core. And the chorionic villi tissue does not always reflect the fetal genotype. And then going back to our original pictures, there are two basic mechanisms by which an aneuploid cell line would be confined to the placenta. The first is trisomy rescue that's occurring early in the cleavage stage embryo, in which the aneuploid cell becomes isolated to the trophoblast while the euploid and rescued cells are isolated to the inner cell mass. The other potential mechanism is a mitotic error of the late cleavage or blastocyst stage that's isolated to the trophoblast or the portion of inner cell mass that gives rise to the extraembryonic mesoderm. Mosaic aneuploid results on CVS should be interpreted with caution, and follow-up testing is necessary to determine the full extent of the cells that share these abnormal chromosomes. And something that's important to remember is the CVS diagnosis of confined placental mosaicism for trisomy 15 may be the initial clue that uniparental disomy could be present and may lead to an affected child. Therefore, all cases in which trisomy 15, either complete or mosaic, is diagnosed in the placenta should be evaluated for uniparental disomy by amniotic fluid analysis. In addition to chromosome 15, chromosomes 6, 7, 11, 14, and 20 are known to contain imprinted regions, and they require similar follow-up. In terms of the CVS, mosaicism occurs in 1% of all samples, but is confirmed in the fetus in 10 to 40% of those cases. If the fetus is involved, there's a high risk for significant phenotypic consequences. Abnormal results are more likely to reflect true fetal mosaicism in a culture than in a direct preparation. Mosaic trisomies 13, 18, and 21 were confirmed in 19% of fetuses. And uncommon trisomies are only involved the fetus in 3%. And sex chromosome mosaicism was confirmed in 16% of the fetuses. So I think for me, the big takeaway was if it's like 13, 18, 21 or a sex chromosome, it's more likely to affect the fetus, or if it's any of the other ones, it's less likely that the fetus is involved. In terms of next steps of what to do with this result, amniocentesis can be performed to determine the extent of fetal involvement. And then there's the possibility of false negative amniocentesis results. I wanted to talk about NIPT next. So NIPT comes from the cytotrophoblast and syncytiotrophoblast of the placenta, and they are responsible for the majority of fetal DNA fragments in the plasma. So this was just another nice illustration that goes over the blastocyst stage embryos and where that ends up being in the fetus and the placenta. So this is normal when there's no mosaicism. If you have affected cells in what ends up becoming your placenta, you can have a false positive, but this would be confined placental mosaicism because you can see the fetus is not affected. If you have cells that are affecting your inner cell mass, so your fetus is affected, but there's nothing in the placenta, so you would get a false negative. And here you have true fetal mosaicism. And if you have the sample in both parts, you have your placenta affected as well as your fetus, and this would be a true positive. And you would have true fetal mosaicism in this case as well. So how should a positive NIPT be followed up? You can do CVS at 11 to 13 weeks or amniocentesis at 15 weeks. The CVS is you're taking components of the villi, syncytiotrophoblast, middle cytotrophoblast, and inner mesenchymal core. You can do your direct method, like we talked about, which will give you an immediate analysis, or long-term culture, which is where you're culturing your mesenchymal core tissue, which takes about a week. So recommendations to eliminate complete placental mosaicism from a CVS result. So you want to evaluate all cell lines. And so you want to analyze your uncultured cytotrophoblast and long-term cultured samples that come from your mesenchyme. If all are aneuploid, it should be reported to the patient. If either are mosaic, then it would be important to do an amniocentesis to rule out true fetal mosaicism versus complete placental mosaicism. And then an important caveat is that low levels of true fetal mosaicism can result in a negative amniotic fluid culture. And lastly, I just wanted to go through some examples of autosomal mosaicism. So trisomy 21, mosaicism affects 1 to 2% of cases. There can be significant variability in the phenotype. Some may have the same phenotype as someone who is a true T21, or some may have milder phenotypes. And there's a risk of leukemia and myeloproliferative disorders. Trisomy 8 is rare. It occurs in 1 in 25 to 50,000 live-born infants. It is increased risk in males, 3 to 1. There are abnormal ultrasound findings, including agenesis of the corpus callosum, as well as ventriculomegaly. Lab abnormalities, you can see an elevated MSAFP. Fetal involvement is not excluded by amniocentesis, but is more often detected in skin and tissue biopsies compared to lymphocytes. There is significant phenotypic variation of trisomy 18 mosaicism. You can have agenesis of the corpus callosum, the ventriculomegaly. You can also have skeletal and joint abnormalities, congenital heart defects, deep palmar and plantar creases, moderate to severe intellectual disability. You can also see normal life expectancy, and there is some potential association with malignancies. And there are other autosomal mosaic trisomies. So trisomy 7 is what we see in maternal uniparental disomy with Silver-Russell syndrome. You can see FGR, a large head, body asymmetry, motor and speech delays, and normal intelligence. In mosaic trisomy 14, there can be growth and intellectual delays. You can see tetralogy of Fallot or body asymmetry. And then mosaic trisomy 9 can have growth restriction, mycognathia, bulbous nose, low set ears, cleft palate, congenital heart defects, hypoplastic genitalia, as well as renal and brain abnormalities. In terms of the sex chromosome mosaicisms, you can have Turner syndrome is sometimes seen as a mosaic, and it's seen actually in 50% of cases. You can have 45X with 46XX, 45X with 47 triple X, or 45X mosaics with X chromosome anomalies. And this is the result of sex chromosome non-disjunction during the post-zygotic cell division. And you may see milder clinical phenotypes depending on what tissue is affected. In terms of Turner syndrome with Y chromosome mosaicism, so this is actually seen in 10 to 12% of Turner syndrome patients, and you'll see a cell line with Y chromosome material. Considered if the sex chromosome material of uncertain origin on karyotype, or if there are signs of virilization. Phenotypically, you may see either your typical Turners, your overtesticular disorder, so you might see genital ambiguity, or a normal male phenotype with infertility. And there's also the risk of gonadoblastoma. So in conclusion, true chromosomal mosaicism is uncommon. Mosaicism is caused by post-zygotic non-disjunction or mitotic errors with trisomic rescue. Mosaicism results in significantly variable phenotypes. When mosaicism is diagnosed on CVS, you need to evaluate for complete placental mosaicism. If there's complete placental mosaicism, you'll have a normal fetal phenotype. And CVS can be used to confirm an abnormal NIPT, but requires evaluation to rule out complete placental mosaicism. And that's it. If anyone has any questions.
Well done, Jen. Really great review on mosaicism. And it's funny, Becca, actually, she's doing well in her new role as an attending, but she had reached out because she actually had 2 cases just this last week where cell-free DNA screening in 2 different patients came back positive for 45X, However, at the end, their NTs were within normal range. So we had a good discussion that for both of these, that confined placental mosaicism was high on the differential, and that if the patients could could wait for an amniocentesis, that would be preferred. But that if CVS was an option for them for the early answers or due to parental anxiety, that if 45X was confirmed on karyotype from the CVS, that an amnio would be considered, would be recommended. And especially if there was any hint of mosaicism, then an amnio would also be recommended. So just very timely and really well done. So thank you.
Thank you.